Hi everyone, let's talk about heart failure. So when you think of the word heart failure, I want you to think of pump failure, which means that there is something going on with the ventricles, which does not allow them to do their job properly. So the heart is too weak to pump efficiently, cannot provide proper cardiac output to maintain the body's metabolic needs. So we need a good cardiac output in order to perfuse all of our organs so that we don't get organ damage and ischemia. So our ventricles either have a contraction or a filling problem. So either they cannot contract very well, the ventricles are weak, or they cannot fill properly. Okay, so maybe there's something wrong with the ventricle itself. Here it's hypertrophied, causing a very small amount of blood. So what is the etiology of heart failure? So hypertension is actually the primary etiology of heart failure. There are many others. Anything that can cause any type of muscle damage or hypertrophy, scar tissue, infection can cause heart failure. So arrhythmias, MIs, coronary artery disease, valve disease, recreational drugs that cause a heart to be very tachycardic, and infection, so pericarditis and myocarditis. So I'm going to go over a couple of terms first just to get us in. So we have diastole, which is the ventricles. They fill up with blood and the ventricles are in a relaxed state. So here, if we had we have our right ventricle here filling up with our venous blood, and it comes in at a nice rate, and everything is nice and loose here, and it fills up to its maximum capacity. Once this is at its maximum capacity, it's called end diastole. And then systole is the contraction. So that's when this then right ventricle actually contracts to push this blood up through the pulmonary arteries and into the lungs to be reoxygenated. And the same goes for the left ventricle as well. So systole is resting and filling. Diastole is resting and filling, and then systole is actually the contraction that pushes the blood through to either your body or your lungs. So cardiac output, that's what CO is, cardiac output. That is when blood pumped out to the body per minute. So the amount of blood pumped out of the body per minute. This is important for perfusion. If our blood is not pumped out appropriately, then we're going to have less oxygenation and our organs are not going to be perfused. So we calculate cardiac output by heart rate times stroke volume. Stroke volume is actually the amount of blood being pumped out of a ventricle with each beat. And it is affected by three things. It is affected by the contractility of the ventricle itself. It is also affected by preload and afterload, and we will be talking about preload and afterload. So cardiac problems, if we have low cardiac output, I already said this, less oxygenated blood to the body, and then if we have good cardiac output, we have good perfusion. So let's talk about preload and afterload. Some of you might know this very, very well, and for others, it's very confusing. So I'm going to go over it fairly well for you, and hopefully this helps you understand. So preload. Preload is that, remember, diastolic function. It's the end diastolic function. So right here, preload is when the ventricles get filled up with blood from their corresponding areas. And then the end diastolic is once the ventricle is filled up to its amount prior to contraction. So preload, no contraction has happened yet. Now we might want to change this amount of preload because maybe they have over amount of fluid that is filling up and stretching this ventricle too much. So we can, or maybe there's not enough. Maybe someone is in shock and we need to perfuse their organs better. So we can increase the preload with fluids, drugs from our sympathetic nervous system, agonists and vasoconstriction medications. Those all increase either the amount of fluid or how our sympathetic nervous system works to increase heart rate, increase blood pressure, and vasoconstrict. That will all increase the preload. We can also decrease the preload. We can use diuretics to decrease the fluid volume. And then we can also use vasodilators like nitroglycerin. There are a few vasodilators like nitroglycerin that open up the vessel, and because it's wider, it then it goes a little slower and it helps with the workload of the heart. Okay, so afterload. Afterload is the resistance that the blood comes up against when trying to pump the blood out of the ventricle to the body or the lungs. This is systole. Okay, systole. So when the ventricle contracts, systole, and it's pushing on the ventricle, it will then push the blood either to the body or the lungs. That is called the pressure or the resistance, sorry, is called afterload. So the resistance is the afterload. So we might have resistance here. If we have fluid overload, for example, and so we're getting resistance from our pulmonary vascular system, and there's a high pressure in there or high pressure in the arteries, or there's some aortic stenosis, then the blood that's going to be pushed into those areas is not going to have a nice free open area for it to rush into. And so it comes against some resistance. That pressure that the blood is going up against is afterload. Okay. So let me show you here the right ventricle. So the right ventricle has to, with the pressure, has to open up the pulmonic valve and overcome the pulmonic vascular resistance, otherwise known as PVR. Okay, so if the right ventricle isn't pumping with a good amount of force, it will not be able to get all of the blood from the right ventricle into that pulmonary artery. Okay. The left ventricle, same thing. It has to go through the aortic valve and it has to overcome the aortic vascular resistance, the AVR. And if the left ventricle is not strong enough to go up against that resistance of the aorta, then it will not properly go through to the body, decreasing cardiac output, and there will be some fluid left over or some blood left over in this left ventricle. So we can also manipulate the afterload. So the afterload we can increase by using vasoconstrictors. The vascular resistance can increase by if we have vasoconstriction, if we have aortic stenosis, hypertension, or pulmonary hypertension. Vascular resistance can decrease by vasodilators, diuretics, nitrates, and morphine, or fixing the problem. If we have some aortic buildup of plaque, then maybe if that plaque is dissipated with healthy living and medications, then there's not going to be as much resistance for this blood to pump out. Okay, let's show you this little cartoon here, because sometimes they help as well. Okay, so preload is the blood coming through, in this case, this is the right, and it fills up this right ventricle. Okay. Once this ventricle is filled, you can also call preload and diastolic pressure, because once this ventricle is filled and ready to be pumped out, but before it is pumped out, that is preload. And it's actually the amount of pressure on the ventricle muscle itself. The preload is the amount of pressure on the ventricle muscle. Okay, so preload can be increased. So the pressure on this ventricle muscle can be increased by hypervolemia, cardiac valve issues, heart failure, regurgitation. Afterload is the ventricle now trying to contract to push the blood out into the, this is the left, so out into the aorta, out into the body for the body to be oxygenated. However, if there's something, the ventricle is fine, it's pumping. This isn't a pump problem. But if there's something blocking its way, there could be extra fluid, there could be a backup of blood, there could be some vasoconstriction going on, then that pressure that the ventricle has to use to push the blood through that narrowed opening is increased, and that is the afterload. The afterload is the increased resistance because it's meeting resistance right here, okay? So let's quickly just review on our blood flow, okay? So we're going to be talking about right-sided heart failure, and we're going to be talking about left-sided heart failure. Left-sided is what we're going to go into the most because it is the most common, and left-sided actually causes right-sided heart failure. So let's just talk about the right side here. So remember, our right side is our venous blood. So our venous blood comes up from the inferior vena cava right here, and this comes down from the superior vena cava into the right atrium, goes through the tricuspid valve right here, and then down into the right ventricle. Okay, once it is filled up, it reaches end diastole, then it contracts and the blood goes up into the through the pulmonary valve, into the pulmonary artery to the lungs to become oxygenated. Okay. So if we have, remember we were talking about with the pulmonary, we can have a backup of blood from the lungs that don't allow this pulmonary artery vein to be dumped into the lungs. So it backs up, and it can actually back up into this right ventricle, causing hypertrophy. Okay? And it causes the muscles to be weak and it just isn't working properly. That can be a sign that we could potentially get some heart failure from that. Now let's look at the left-sided heart failure. And remember, our left-sided heart, the blood, it is our oxygenated blood now going from the lungs to the body through the aorta. So the blood comes in to the left atrium, down the mitral valve, into the left ventricle. Now the left ventricle has the most pumping power. Okay, this is much stronger than the right ventricle. And that makes sense because this is what we need to be really strong to pump all that oxygenated blood up into and circulating our body. Okay, so it's going to contract now. It's going to go through systole, and the blood is going to go up the aortic valve, and then from the aorta to the circulating into the body to oxygenate our cells.